We've got a clinical case, my beloveds. 62-year-old man with a history of long-standing hypertension presents with sudden severe chest pain that he describes as tearing radiating to his back. His blood pressure is 180/100 millimeter mercury in the right arm and 150/90 mercury in the left arm. Okay, on exam you notice a new diastolic murmur along the left sternal border. ECG shows no signs of myocardial infarction. Where is troponin? Where is echocardiography? What is the most likely diagnosis? Acute aortic dissection type A, exactly. Acute pericarditis, where is troponin? No. CT elevation, ST segment elevation, myocardial infarction, where is troponin? No. Pulmonary embolism, okay, where is D-dimer? No. So, okay, my beloveds, here we've got, of course, acute aortic dissection type A. Unfortunately, we do not have neither troponin, neither the D-dimer, neither echocardiography. Okay. So, why is this correct? Sudden tearing pain radiating the back, specific for aortic dissection. Blood pressure difference between arms, of course. New diastolic murmur, aortic regurgitation due involvement of the aortic root. Long-standing hypertension is the main risk factor, of course, as well as smoking, actually. Normal ECG helps rule out myocardial infarction, and troponin. Anyway, this presentation is a classic for Stanford type A aortic dissection involving the ascending aorta. So why other options incorrect? Acute pericarditis. Pain is usually sharp and improves when leaning forward, and there is always history of something viral infection or myocardial infarction. Here, nothing in history, and usually pain is usually sharp and improves within learning forward. It's a pericarditis. Pericarditis produces a pericardial friction rub, not a diastolic murmur, definitely. Blood pressure difference between arms is not typical. Next, ST segment elevation myocardial infarction. We do not have troponin, but anyway, pain is typically pressure-like, not tearing. ECG should show ST segment elevation, ST segment dense, but here ECG is quite normal. And MI doesn't usually cause asymmetric arm blood pressures, never. And finally, pulmonary embolism. We do not have D-dimer, neither troponin, I repeat. So pulmonary embolism causes pleuritic chest pain, dyspnea, tachycardia, and does not cause tearing pain radiating to back, arm blood pressure differences, and diastolic murmur. This is a aortic dissection, period.